Good evening, and welcome to the second session of a three-part webinar series on pelvic endometriosis, sponsored by the American Institute for Minimally Invasive Surgery Educational Division. My name is Dr. Asha Bawal. I am pleased to serve as your moderator for today's program. I'm especially grateful for American Institute of Minimally Invasive Surgery for sharing this educational session and helping bring together experts who are dedicated to advance the care of patients with endometriosis and chronic pelvic pain. Now, despite the advances in surgery and medical therapy, one of the greatest challenges in endometriosis still remains the delayed diagnosis. Our discussion today is about evolving approach to early stage of endometriosis with particular attention to diagnostic testing in patients experiencing chronic pelvic pain. Our objectives are to explore the relationship between early stage disease and pain symptoms, review the current diagnostic protocols for endometriosis, and discuss the paradigm shift from relying primarily on surgical diagnosis to accelerating and streamlining the diagnostic workup to facilitate earlier intervention and improve patient care. We are fortunate to be joined by three distinguished faculty members. Our first speaker is James Kondrup. Dr. Kondrup is an MIS surgeon and a CNY fertility specialist. He's a board-certified surgeon in obstetrics and gynecology, and he's accredited in minimally invasive surgery. Our second speaker is Dr. Andrew Levine. He's the Chief Executive and Scientific Officer of Kefera Diagnostic in Framingham, an emerging company focusing on addressing diagnostic challenges in women's health. And our third speaker is Dr. Mark Noor. He's the Director of Endometriosis and Neuroenterology Institute in Sparks Glencoe. He has invented a non-invasive rapid test for endometriosis with the test accuracy of 98 to 99% range, and is widely considered groundbreaking, filling a vacuum in diagnostic testing for the disease. So today's agenda consists of three presentations. Dr. Kondrup will begin with 20 minutes of lecture, followed by Dr. Levine's presentation, and then Dr. Noor. And following the lectures, we will open the session for questions and discussions. We encourage all participants to submit their questions throughout the webinar using the chat feature, and we will connect those questions and address as many as possible during the discussion period at the conclusion of the presentations. Your participation is an important part of making this a productive and engaging educational experience, and we thank you for joining us. And it is now my pleasure to introduce our first speaker, Dr. James Kondrup. Dr. Kondrup, the floor is yours.
Asha, thank you so much. Thank you so much. And it's an honor to be here. And thank you, AIMIS, for having me. I love teaching. I love presenting. And hopefully I can give you a surgeon's view in non-invasive diagnostic tests. So I've been an endometriosis surgeon now for around 38 years. And I'm still actively practicing. I'm in the OR at least 2-3 times a week. And I deal mostly with fertility patients. So I'm a little skewed in what I see, and also a lot of endometriosis. So I'll give you my perspective and how we use these tests, etc. So no disclosures right now, which is totally fine. So what's the issue? Why do we need new tests? What's the problem? You know, what's the question going on? Aren't we doing a great job of diagnosing endometriosis? Why do we need these tests? Well, you know, a lot of women, and this is an underestimation probably, have endometriosis. And it's not only our country, but many countries, difficulty in diagnosing and also treating endometriosis. It takes an average of 4 to 11 years to diagnose the endometriosis from symptom onset. Notice I said symptom onset. And up to 50% of women with infertility have endometriosis. And conversely, 30 to 50% of women with endometriosis have infertility. So it is significant. Silent endometriosis is the one that gets us most of the time. From a fertility standpoint, we're still, trying to figure out where endometriosis falls in the fertility world. Does it affect implantation? We know that women with endometriosis are subfertile. They're not necessarily infertile. But how does it affect the in vitro process, the fertility process, and how have we changed over the years? So do we need any tests for symptomatic women? Well, 20 to 40% of symptomatic women have no findings on laparoscopy. Well, for me, I'm not sure that's true because I believe in it looks like a duck principle. What do I mean? Well, a woman comes into your office, a duck walks into your office and it's quacking, looks like a duck. You don't need to do a DNA test on the duck to know it's a duck. It's a duck, right? And so when a woman comes in and she's complaining of horrible periods that are progressive, she's missing school, she's missing work, you do an ultrasound and you see an endometrioma on each ovary, and you say, gee, I'm not sure if you have endometriosis. It's sort of like this is where the difficulty is. And so the more endometriosis patients you see and treat, the better you get with a diagnosis. So we have women coming in that have open fallopian tubes. They have great sperm count. They've been trying for years. And then when you quiz them, they tell you, oh, yeah, I have horrible, painful sex. I can hardly have sex with my husband anymore. Or my periods are so bad, I'm curled up in a ball, or I'm missing work, or it's getting worse over the years. And in this situation, I think this person's, going to the operating room in my view. I mean, you can do medical therapy. I'm a surgeon, so surgeons usually do surgery. And I've been doing that for many years. So I like to, and also I'm OCD, so I like to really know what's going on as opposed to blindly treating, but that's a whole different discussion. We just discussed that a few weeks ago. So for me, if it looks like a duck, it probably is a duck. So when I take someone to the operating room, it's very unusual for me to have somebody and not find endometriosis. And I'll, of course, tell you how these tests help me. But what do you do about the women with silent endo? Well, we've all done surgery and we've been doing it for years. I've been doing it for 38 years. And Steve will tell you, you'll find a patient that has horrible endometriosis or a C-section or something like that. And you'll ask her, are you in horrible pain? And they'll go, no, I don't have any pain at all. So the amount of endo doesn't always really correlate with pain and vice versa. So I think what happens is that you're not sure if you're going to find a duck or not when you look in there. And I think for us, this is where the testing is very, very helpful. And you'll see in a few minutes, and Dr. Noor and Dr. Levin will speak to their tests, which I'm not going to go into detail because they're here, which is fantastic. But it's important to know how we use it. And also I want to discuss with you how we are starting to abuse it. And we'll go over that too. But let's take a look at some of the most common tests that are out there that we use. So in our practice, CNY fertility, we see people from all over the United States and we see people from all over the world. And I have people that fly into Sarasota, Florida for surgery. I've been doing endometriosis surgery for many years. And now I have Asha, I can send her some patients in Houston, which would be fantastic. They don't have to fly so far. So Receptiva DX was one of the first tests we started using. And this test doesn't actually look at an endometriosis marker. There are no endometriosis markers per se, unless my speakers tell me otherwise. But they're looking at a marker called BCL6. It's an inflammatory marker that measures inflammation and also progesterone resistance. And you can add a CD138 to that also. So when you get the Receptiva DX test kit, first of all, it has to be mailed to you. You can go to the website. But in our office, we do it so often that we actually keep the kits in our office. The cost is around $700, maybe a little more, $900, plus the biopsy. Now, in Florida, we're in a really challenging situation because in Florida, very few patients have infertility coverage. And this is where these tests for us right now really come to be very helpful. So the initial validation was done for an IVF outcome, not as an endometriosis diagnostic test. That's important to realize. When you look back at the studies, you have to look at the study and what did they study in the study? Because when you start taking those results and extrapolating to other decisions and treatments, I'm not sure we should do that until further investigation is done. But you can have a positive Receptiva DX. There's a threshold level. And that can occur with endometriosis, adenomyosis, and hydrosalpinx. So it's important to know it's not a pure endometriosis marker. The initial study was done around 2016 in asymptomatic women, and then in 2019 they compared medical treatment with laparoscopy and no treatment at all. And that's how they came up with the results. And this study is the one that initiated the, quote, 2-month suppression treatment for women who were asymptomatic. Okay. And this is where we get lost. You got to understand what the study covered. So this involved women who were asymptomatic that had a positive marker. They were treated for 2 months with suppression. I believe it was Lupron, but I'm not sure. We use Lupron, we use Orlissa, and we use Myfembree. So they were given 2 months, and the implantation rate, this was an IVF study. It didn't measure pain, it measured IVF outcomes. The study showed that there was a significant or an increase in the implantation rate, okay? People that were treated for 2 months with suppression that had a positive Receptiva DX. Now, the CD138, a lot of physicians don't know about that, and you should. So what it does is it measures plasma cells present in the endometrium, and that's a biopsy. And the Receptiva DX must be done during the luteal phase or a simulated luteal phase. And if you do it any other time at egg retrieval, or if you do it early in follicular, you're not going to get a good diagnosis. You're not going to get an accurate diagnosis. And it's also an endometrial biopsy. So the patient has to have an endometrial biopsy. And, each center charges a different amount of money for those biopsies. Sensitivity, 93%, specificity, 96%. And they use this random threshold of 1.4. And I think I don't know if I have positive receptiva in here, but so anything above a 1.4 is considered a positive test, and that's how they do it as their threshold. Now, as a surgeon, I've been doing the Receptiva DX test long enough to tell you that I've had a few patients where they have symptoms, a negative Receptiva DX. I do laparoscopy, and she has a good amount of endometriosis. And women that have a Receptiva DX that's positive, and I get in, and I have no endometriosis. And I tell the patients that when I take them to surgery. But the other thing is, don't forget what I said earlier, adenomyosis can also give you a positive test. Hydrosalpinx is pretty obvious. You'll see that, and usually we know that ahead of time anyway. And sometimes you find endometriosis with the hydrosalpinx. And we take out a lot of hydrosalpinx in fertility because it cuts down on the success rate with IVF. So the cost is $750 to $1,000. In Florida, very little coverage for infertility. So if I get a positive Receptiva DX marker, I'll automatically put in an N80.9 diagnosis code in the patient's chart. That's other endometriosis, where N is N80.3 is an actual visual diagnosis of endometriosis. So how does that help us? Well, it helps us get surgery, because once you submit that to the insurance companies, now we're treating endometriosis, not infertility. So that's extremely helpful. I would say 95% of the women in Florida do not have coverage for infertility diagnosis. Now, some people are starting to use this in other ways. So what they're doing is they're saying, well, if you're 1.4 or 3.5, you have minimal endometriosis with a 1.4 and a lot of endometriosis with a 3.5. Well, that's not accurate because the study never studied that, so it didn't show that. So people are using that, and some people are starting to use it as recurrence. They're treating the endo, then they're repeating the biopsy to see if the marker has gone away or gone down. There's no studies on this. So people are starting to extrapolate this and use this in ways. Now, the important thing is when you tell the patient she has a negative Receptiva, you're not telling her she doesn't have endometriosis. What you're telling her is there's a good chance you don't, but I can't be 100% sure. So how does this play in a role for us? Well, if a patient comes in and she's in a lot of pain, she's been trying to get pregnant for years, for me, she's getting a laparoscopy. I'll save her $1,000, $750 for something else. But if she has normal tests and it's pointing, don't forget, laparoscopy is a basic fertility test in my mind. It's a basic test. We do a couple of 5mm incisions, and they don't see it. It's down the bikini line. Every incision I make inside the umbilicus, you take a look, you treat it, and patients want to know also. But if they have pelvic pain, they have painful sex, they have a lot of symptoms, you want to go in and treat that also. The next is HerResolve. HerResolve is a blood test, actually, that was introduced by HerInnova Life Sciences. Excuse me. Now, this test is for people that have symptoms. So when it was originally studied, it was for women who had symptoms, and they use AI to integrate multiple microRNAs and protein biomarkers. Now, don't forget, this is their special formula that they use. And so this is to reinforce people that have symptoms. It was validated as an endometriosis biomarker in symptomatic women. So that's really important to know. Well, how do we use this? Well, I'm not sure how we're using this. So if we order this test and it's $600 as a blood test, excuse me, and if we order this test and it comes back positive, it's really, really good sensitivity, specificity that they're going to have endometriosis. But don't forget, these women have symptoms. So now we're starting to do this on women that have clear symptoms of endometriosis. Okay, what if it is negative? I had a patient just 2 days ago. She said, I don't have endometriosis because her resolve was negative. And I said, well, that's not necessarily true. It just means your test is negative and you may have endometriosis. We don't know that. And a couple of restrictions, no gonadotropins for 1 month. And some people are saying also no antibiotics for a week. Now, the other thing is her resolve is not approved in all states. For example, we have offices in several states. We can't do that in New York. We can do it in Florida. I believe we can do it in Norfolk, Virginia, and maybe Houston. I'm not sure 100%. It's real easy. It's a blood test, but it's $600. And that price was basically randomly set. And the patients pay for that up front. They have their blood test. And if it's positive, once again, that gives us a diagnosis. Now, some people say that if you as a physician or a healthcare provider, notice I say healthcare provider, feel that the patient has clinical endometriosis, you can put that code down in the chart, clinical endometriosis. And so that's one of the ways we get to use medicines for suppression and get insurance approval for that. All right, so they're using it on asymptomatic women. Asymptomatic women come in, oh, I can't get pregnant. I have infertility. I don't know why, what's going on. And so we're using that on asymptomatic women. Now, we are getting some positive results, but it hasn't been studied yet. So more studies need to be done on asymptomatic women to see what the sensitivity and specificity is when you're doing the HER resolve. Will adenomyosis give a false positive? We don't know, but a lot of outpatients have adenomyosis. And adenomyosis is one of those forever mysteries for me. How do you diagnose it? How do you treat it? What do you do? Does it affect implantation, et cetera? So these tests cross over, and I like to hear what Dr. Levin and Dr. Noor say about their test in adenomyosis. So that's really important to hear that. Because if you think about it, adenomyosis is endometriosis in the muscle, correct? So we're still juggling with that, especially in the fertility world, where we're actually wondering if adenomyosis has an effect on implantation, and people are thinking about it. So this is what a test looks like, and you can see here it says she is endometriosis not present or not suspected or not detected. That's a heavy statement because at the sensitivity of 80%, you're going to miss a few people. So I would say endometriosis is probably not suspected. I guess that's okay, but you have to know what to tell the patient. It doesn't mean you don't have endometriosis. It means you probably don't have endometriosis. All right, so that's important. And so we're doing it on a lot of people, and I'm not sure that we're following any certain guidelines. Who gets it? Just asymptomatic or symptomatic? The test was studied in women who are symptomatic, so it's a confirmation test, okay, if there's any doubt. Now, can you use this in young women? I think most of the problems with endometriosis diagnosis go into laparoscopy. I've never had a 30% negative endo rate on laparoscopy. I just don't know why. I mean, careful questioning and progression and things like that, that's really important. And if you see endometriosis signs, a abnormal MRI, when you have a good MRI, we're in Florida. I don't know if it is in Orlando. I know Orlando does some great MRIs and so does Tampa, but there's an MRI in every corner in Sarasota. And the quality that I get from the MRI is just horrible sometimes. And so I can't always trust my MRI to tell me what's there. Okay, the MDOM test, I'm not going to go into that in detail, that's for sure. So introduced by Cafera, I was approached by the rep, and by this time we were already doing the HER resolve and the Receptiva DX test. So when I was approached by Cafera, we at that point were curious, but we weren't interested in doing another test because we were already sort of confused about the test we were already doing. So very important, confirms the presence of endometriosis in symptomatic women. And once again, I'll have, I think Dr. Noor is going to go into that in detail. No, that's Dr. Levin. Sorry about that. And these are biomarkers, great stuff, fantastic findings of brain-derived neurotrophic factor and a CA-125 level. Sensitivity, and Doc, please correct me on all this later on. Sensitivity 50, specificity 90%. So you can go into that. I'm not going to spend a lot of time on it. All right. Cost, I think it's around $300. I'm not sure. And I'm not sure if it's certified in all states. Once again, we aren't using this test right now. We'll see. More tests on the way. Endo Shore, Dr. Norris here with us tonight. He's going to talk about his test in detail. I'm not going to go into that at all. Endo test, and that's the test that's actually over in Europe. I believe it's in the UK a lot. And so they're using that over there, really high sensitivity and specificity. And as you can see, the market is exploding with these tests. Everybody's racing. They get the best test and the easiest test, right? So we as clinicians are really looking forward to hearing which tests are going to come out on top, which one's easy for us to do, and eventually, of course, which ones the insurances will pay for, right? All right, CA-125, I've had people ordering CA-125s all the time. And it freaks patients out when they get a 40 and they got two endometriomas. Steve McCarris and we dealt with a patient, I think last year, she had 9 centimeter, 10 centimeter endometriomas, and her levels were up, and it's just not reliable. It doesn't help you with endometriosis. So don't do it as a routine test. It's not reliable. Maybe if you're combining it with the other tests, maybe. Ultrasound imaging. I was approached by ScanVio, I think it's called. So they attach this to your ultrasound machine, and it uses AI live with different colors to give you an idea where they suspect endometriosis. We did not get it. We did not use it. I think a lot of it has to do with, do you have full-time sonographers? Do you have good sonographers? And do you have really good ultrasound machines? And what's their training? So there's a lot of different things out there. MRI looks for deep infiltrating endometriosis, and my MRIs are horrible. Sometimes I get them and I can't even read them. I just stare at them and these wavy lines through them and I can't see it. So how do we use it? Well, like I said, Florida, if we get a positive HER-Resolve or Receptiva DX, we're going to give her an endometriosis code. Now, we may treat her medically, but let me tell you something. I don't know of any evidence yet. You got a woman that's dying in pain and you give her 2 months of Lupron or Alyssa or Myfembree. Well, how much of that endo are you treating? And what do you do after the 2 months if she doesn't get pregnant and she still has symptoms? And where did this 2 months come from? This came from the Receptiva study on asymptomatic women. And so some of my patients, in CNY, I mean, some of our patients are being treated by practitioners for 2 months with severe pain. And I'm not sure that's the right way to go. You got to also make sure she doesn't have any hydro. Now, this is good for somebody with no health insurance. They can dish out the money for, and we'll try to get Lupron, we can get a waiver and stuff like that. So how do we abuse it? Well, if the doc walks into the room, they don't need a test. They need a laparoscopy, in my opinion, most of the time. And we're mixing patients that are symptomatic with the asymptomatic. We're treating patients with the asymptomatic study guidelines for 2 months. See, for me, when I find endo on laparoscopy and it's so extensive and it's so deep, and I respect other surgeons, but I can't get all the endo when it's stage 3 or 4. You can't see all the endo. And so they'll get 3 to 6 months of suppression right after that surgery. So with the 2-month thing just kind of sits poorly with me. Don't tell the patient they don't have endo, especially if they're in pain. Don't use it as a threshold to guide severity, because the numbers don't do that. And don't use it for retesting when you think there's a recurrence. There's my slide. I didn't use the AIMIS background, so I figured I'd throw something in at the end. All right. Well, that's my 20 minutes, and thank you, Asha. I appreciate it very much. Hope that was helpful.
That was great. I can see the audience are really into it and a number of questions coming through that. But thank you for that talk. Now I would like to have Dr. Levine. The floor is yours. All yours.
Okay. Good evening, everyone. Let me first thank the organizers for inviting me to join this webinar and share some information about EndomTest, our relatively new test for endometriosis, with you tonight. So first, a bit of introduction about Kefera Diagnostics. I'm the Chief Executive and Scientific Officer. We operate a CLIA and CAP certified laboratory in the Boston area that specializes in emerging and under-recognized diseases such as endometriosis. Because of the emerging and under-recognized part, Much of what we offer is based upon our own scientific research and development work, leading to laboratory-developed tests validated under CLIA. We have a number of other unique tests that serve similar needs where there are no other available options. And EndomTest, which is our test for endometriosis, was the result, whoops, here, one slide ahead of where we should be there. EndomTest, which is our test for endometriosis, was the result of a partnership with Exceltis, a global pharma company headquartered in Europe and focused on women's health, which developed and licensed the test to Cafera for the US market. So I'm going to try to cover briefly these 5 topics just to give you an overview of EndomTest, its clinical value, the development history, some of the clinical study data, what it can help with diagnostically, and sort of a brief summary of the test logistics for actually ordering and using the test. So starting with the clinical, the overview and the clinical value, it's most importantly, it's a simple blood test. It doesn't require anything of the patient other than to give a standard blood draw at any phlebotomy site. And also very importantly, EndomTest is intentionally designed as a rule-in test based on its very high specificity. It's intended for use on any patient experiencing symptoms consistent with endometriosis, not only those dealing with infertility. With this near 100% positive predictive value, a positive EndomTest result provides actionable information to the physician and patient within a matter of days. Lastly, the test is available exclusively in the US from Cafera Diagnostics as a laboratory-developed test validated under CLIA. It's CE marked in Europe, at this time not yet FDA approved. And a bit of history on the development of EndomTest. Development goes back a decade involving extensive research, initial studies done in academic laboratories, McMaster University in Canada. That research was subsequently licensed to Exceltis, which developed it further using gold standard samples from the Oxford Endometriosis Care Center Biobank in the UK. And Exceltis launched the test initially in certain markets in Europe in 2023. And then through our licensing arrangement, we launched it in the US in mid-2025. So still pretty recent. So the key to a blood test is the biomarkers that are analyzed. And endometriosis makes use of 2 markers. So the first is CA-125, which we just heard a little bit about. It's an antigen which many of you are no doubt very familiar with. CA-125 is, it's been known for several decades. It's a glycoprotein that is expressed in many tissues, including reproductive tissues. And it was originally identified as a biomarker whose level in blood was elevated in many cases of ovarian and other cancers. So cancer marker. However, as far back as 1986, levels of CA-125 were also known to be elevated in endometriosis patients. And further studies showed that sensitivity and specificity that could be achieved by measuring CA-125 levels in blood as a diagnostic test for endometriosis yielded an AUC of about 0.9. And so the take-home message was that at a rather low cutoff, 12.7 IUs per mil, CA-125 can be quite sensitive, but not very specific for endometriosis. While at the cutoff level, 35 IU per mil, that's often used in CA-125 assays for cancer, the test proved highly specific, but not very sensitive. Secondly, CA-125 levels in endometriosis patients were generally much higher in advanced stages of disease, ASRM 3 and 4. So, important question would be, how can you take advantage of the known correlation between elevated CA-125 and endometriosis, knowing that CA-125 is not truly totally specific for endometriosis, as was commented by our previous speaker. So One answer would be add an additional biomarker as part of the diagnostic algorithm. And that biomarker for Endom test would be BDNF, or brain-derived neurotrophic factor. And this came about through, again, the initial research and development work at Exceltis, which looked at combinations of CA125 with a variety of different biomarkers and found that the combination with BDNF yielded the most accurate diagnostic results. So BDNF is a protein secreted by mainly neural, but other tissues also, which is involved in many different pathways in the body. But it is present in reproductive tissue. And a variety of studies showed that the blood levels of BDNF are significantly elevated in endometriosis patients versus controls with an AUC of 0.75. And so difference was significant, p less than 0.05. BDNF levels may be related to the level of pain experienced by endometriosis patients, given that it's a neurological biomarker in effect. But interestingly, BDNF levels were not found to differ between stages of endometriosis as for CA125. So Endom test is based upon a combination of three components. And the analytical components are the measurement of CA125 and BDNF in the blood sample. But the additional key to the high specificity of the assay is the incorporation of certain clinical history data, all of which are digested and interpreted by a software algorithm to yield the final result. And this is a proprietary algorithm developed by Exceltis based upon the development study data. So just to return to assay development for a second, in working up the algorithm for interpretation of results, 122 clinical variables were analyzed. And of those, 6 were found to be significant contributors to the accuracy of the final result provided by the software algorithm. So those 6 are incorporated into the assay as is performed today. And along with, again, the measurement of levels of CA125 and BDNF, which is the laboratory part of the test. So to give you an idea of what went into the development and validation studies for Endom test, somewhat over 280 patients, endometriosis patients, and over 90 controls were included in the 2 studies. These are all from the Oxford Care Center Biobank. The endometriosis group included patients representing all ASRM stages, divided roughly evenly in the development study between lower and higher ASRM classes. But in the validation study, the preponderantly representing earlier stages. And results of these studies were published in 2 papers in 2023 and 2024. So, as I mentioned, the assay developers were intent on creating a rule-in assay that would deliver very high specificity. Over 90% was the target, and hence very high positive predictive value. The software algorithm provided the mechanism to achieve this high specificity with a combination of results from CA125 and BDNF proving to be more accurate than either marker alone, and in combination with the clinical data yielding an AUC for the assay slightly under 0.9. So with respect to the sensitivity of the assay for different types of endometriosis, it was found to be most sensitive in patients with combined DIE plus endometrioma at about 70% sensitivity, and least sensitive in patients with superficial endometriosis at about 32%. And endometrioma and DIE individually had values somewhat between those 2 extremes of the range. The average sensitivity across all classes in the development study was 51.5%, and slightly lower in the validation study, again, probably because the validation included proportionally more early or low-level cases than development. Specificity was conversely about 96% in the development study and 100% in the validation study. And that was really to aim again to have a very high specificity assay. So importantly, a variety of potentially confounding conditions were tested, including benign ovarian cysts and uterine fibroids. And these were shown not to produce false positive results on Endom test. The positive predictive value remained about 100% based on these data. And negative predictive value varies between about 65% when the symptoms are pelvic pain and 85% for patients experiencing infertility. So an additional feature of Endom test is its performance in patients who are in a variety of hormonal therapies. There we go. While some of these therapies can reduce the sensitivity or specificity, they don't preclude the use of the test. And as to the value proposition for Endom test in clinical practice, it has the potential to reduce the time to diagnosis versus the current lengthy scenario. And we heard numbers earlier in this range. 5 to 12 years is reported as the length of time it can take to get to a diagnosis of endometriosis. So a positive Endom test result has high enough I'm pressing on the wrong thing here. A positive Endom test result has high enough predictive value that it may help the physician and patient to reach a decision for treatment, including laparoscopic surgery. And various studies have shown that a large percentage of surgeries on symptomatic patients, ranging from 16 to 78%, depending on the study, do not yield a diagnosis of endometriosis. So having a rather simple means via a blood test to enhance the probability that surgery will be a beneficial next step can have value. And to give you an idea of the relative simplicity and turnaround time for the Endom test, this is a sort of a brief schematic of the logistics for ordering and running the test. So a patient visits the physician. If a determination is made to order the test, the physician submits the online requisition form. Patient pays online. Blood sample is drawn and collected. It can be done by any phlebotomist. The FARA provides a blood collection kit to expedite the collection and shipping of the sample, prepaid labels and all of that. Sample arrives at our laboratory. It's tested, and results are returned to the requisitioner via an online portal. Our maximum turnaround time is 14 days. Average turnaround time is less than that, probably about a week. The blood sample is in a standard SST tube, so it's a very standard collection procedure. We are hooked up with collection networks almost nationwide to facilitate collection of blood samples from patients anywhere if there's an issue in doing so. So the whole process is basically very simple. And we have an online requisition form that collects all the necessary information. So here we have the 6 clinical history questions that are asked. Have you undergone surgery, laparoscopy, or other surgical procedure in the past to examine for endometriosis? Are painful periods one of the symptoms that have led to the current examination for endometriosis? How old were you when you first experienced intercourse pain, if ever? How old were you when you first were diagnosed with ovarian cysts, if ever? How old were you when you started regularly using pain medication? And how would you rate the menstrual pain during your last cycle? So these are filled out and sent to us along with the test sample. And after we run the sample, we return a test report, which includes the result and an interpretation, giving further explanation of a positive or a negative result. And that is about it. I think that is all I have for today, but I'd be happy to answer, to address any questions either now, or if anyone wants to contact us later, here is the contact information. And thanks very much for listening.
Well, thank you so much. That was really, really great information about the upcoming test in which we have for this diagnosis. And it's definitely have initiated a lot of questions in the chat. We'll go at the end of our presentation, but I would like to introduce Dr. Noor for his part of his presentation. Dr. Noor.
Thank you very much to AIMIS as well as everyone else for this opportunity to speak to such a great group and interact with my fellow colleagues in the field. Let me get my presentation up. So today I'm going to talk to you about the GIMA biomarker, that is the defining biomarker of the EndoSure test and how it predicts endometriosis. And I will state it plainly up front because this is what everyone says. The test is too good to be true as far as its technology goes. And we'll address that as we go on. The pathogenesis of how this occurs is that endometriosis is a very, whether it's be adenomyosis or endometriosis, it's a very unique tissue that produces two neurotransmitters. One is prostaglandin E2, which causes normal peristalsis of smooth muscle, such as in the uterus, the fallopian tube, but especially in the small bowel, as well as PGF alpha, which causes diffuse severe spasm. So you're setting up a motility issue where you have normal peristaltic waves hitting a wall of spasm, which generates a large amount of energy, which is then transmitted across the abdominal wall. Now, this is unique only to endometriosis and adenomyosis. And no matter where this is in your body, whether it's in your brain or your lung or your abdomen, your pelvis, even a peripheral joint space, it is taken by the bloodstream to the liver for detoxification. And as it does that, it passes through the enteric circulation, creating this severe contractile abnormality. And that is what we are detecting. And in fact, if we think about it, 96% of women who present with endometriosis present initially with bowel symptoms such as dyspepsia, bloating, and things like that. Now, it's also very remarkable to note that these neurotransmitters aren't around for a long time, which gives you an idea of how much has to be secreted by this tissue all the time. They are basically viable for 30 seconds in the human body. Now, what this does is it uncouples the normal governing contractile mechanism of the bowel, the fallopian tubes, or the uterus, and you have uncontrolled small bowel activity in the 15 to 200 cycle per minute range. However, we're concentrated in the 15 to 60 cycle per minute range based upon the predicate publication that showed these abnormal rhythms. The device we use to record this is called a tricorder, an homage to Star Trek, because we are sensing energy across the body to detect disease. The beauty, by the way, of this is that not only can we tell you when it's abnormal, but we can tell you when things have gone back to normal using the same technology. This technology is since 1998. We've been working for 24 years on this to this point. And this was published by Dr. John Mathias, a fellow gastroenterologist, who was placing nasogastric tubes into women for 24 hours at a time, not looking for endometriosis, but looking for small bowel contractility. And he discovered that women with endometriosis had these very peculiar contractile patterns. Now, what that looks like is this. A non-endometriosis patient has peristalsis, so you see waveforms as the wave is carried down past the transducer, and that's typically around 11 cycles per minute. Normal bowel is 10 to 15 cycles per minute. Now, this is an endometriosis patient who instead is found to have simultaneous spasm occurring at the same time with very high frequencies, in this particular case, a woman with 44 cycles per minute. Now, John brought this technology to me in 2004 and asked me to redevelop a device I had already created for gastrointestinal purposes so we could change the filters and look at these high frequencies. We brought back some of his patients, and this is what we did. We placed electrodes on the patient's abdomen. We're able to predict the exact same cycle per minute deformity taking place. And this is exactly what you see here in the EndoSure result, is these frequencies are duplicated here in this 44 cycle per minute range. We tested about a half of the patients in his original paper and then began doing our research over time, spending 10 years studying over 4,500 women with every disease known to the gynecological, urological, or gastrointestinal community to be sure that there was no confounding illness that did the same thing. Now, when you look at this study, this is what's called a running spectral analysis. And you see these red lines are the baseline period. The two black lines correspond to when a person will drink water to get things to activate the bowel. And then the blue area here is the post-water load period. Now, this is a normal patient. Contrast that on the right with these two patients who have endometriosis, and you can see these very distinct parallel disturbances within those frequency patterns. Let me blow that up for you real quick so you can see this difference. Now, something that's also very interesting along the way that we found is this is genetically controlled. So in other words, a mother and a daughter will have the same pattern, which would be distinct from a non-related neighbor down the street. So this actually runs in families, and we can see these patterns within related individuals. Now, the problem here is that, I can't give curves to doctors to make diagnoses. And so what we have to do is we have to measure the area under the curve. And when you do that, you see something really astounding. And so the endometriosis patient is above, the normal patient is below. And if we look at this 15 to 20 cycle per minute range, look at the difference between a normal patient who generates area under the curve of 1 to 3, and now the endometriosis patient is sitting in the 40 to 80 range. Same thing for other frequencies, significant multiples because they have such abnormal activity caused by those simultaneous secreted neurotransmitters. And by the way, this is the same. It doesn't matter about your body morphology. It doesn't matter about your stage of disease or where the disease is located. If it's anywhere in your body, it will have this effect on your small bowel. The device itself is a handheld device. This is an analog to digital converter. And so the signals that come from these specialized pads that go on the upper abdomen of the patient transmit that signal. It's converted to digital, which then goes to the computer and runs its program against a predictive formula that's been developed over time during the development of this disease. These are unusual pads. They're 4 centimeters across. They sense across the entire pad width. And so we're literally picking up all the signal from the pubic symphysis to the xiphoid process. And so we can see everything happening inside the abdomen and pelvis. Now, here's how the test is done. You'll come in after an overnight fast, and then the electrode pads will be placed on your abdomen. The device will be hooked up, and you'll be asked to drink a glass of water until you feel full. This causes distension of the gastric proximal portion of the stomach, which activates the pacemakers, which then brings out these abnormal rhythms. And now comes the fun part of the test. For the next 30 minutes, you're going to lie in a reclining position. Think mini spa day. No husband, no children, no boyfriend, no dogs, nothing to bother you. And at the end of that 30-minute period of time, you get a result that says you have endometriosis or not. In fact, not only do you get a result that says do you have it or not, but we also provide an additional result that is tied, we call it the activity index, that is directly tied to the metabolic activity of the endometriosis tissue, which gives us the advantage not only of diagnosis, but tracking response to therapy. And I'll show you some things on that next. So we designed a trial to be able to prove that we thought we had a good test. And this is a dual control trial, with the cohort 1 being the first control group of non-endometriosis women who were healthy normals, as well as women who had pain due to other causes, IBS, IBD, interstitial cystitis, you name it, we studied it. And they were included in that group. And then cohort 2 were women who had just undergone laparoscopic surgery with biopsy who were positive for endometriosis. So we had a known negative and a known positive control group, against which we tested the proof of concept or validation cohort, which was 49 women who had abdominal pain of unknown etiology, negative ultrasounds, negative MRIs, possibly suspected to have endometriosis. And they underwent our test. The surgeons were then blinded, and then they were operated on. And during the course of the study, what we found in that control group was of the 49 women, the test predicted that 47 would be positive and 2 would be negative, and that's exactly what the surgical findings showed. If we look at the demographics of those groups, the only thing abnormal, and it was a representative ethnic group across multiple ethnicities, pain scores were the only thing that were different in the normal group, which was cohort 1. Everybody else, the endometriosis groups, had much more pain, as you would expect. Now, when you analyze the data across not only the different frequency bands of, you see here, 15 to 20, 20 to 30, 30 to 40, 40 to 50, and across every single frequency harvesting time, which would be baseline prior to water load, and then 10 minutes after, 20 minutes, and then 30 minutes after. Look at these p-values, compare it to the normal group against the endometriosis groups. We're looking at p-values of 0.0001, 0.05. These are significant values showing that if you have endometriosis, you're going to have a positive test. Now, what we do next is you go in and you look at all of the data. But before that, I'll tell you just a brief story. I got called at 3 in the morning by our NIH statistician who said, get out of bed and look at your computer because I'm going to send you the ROC curves of your data. And I wasn't too pleased about getting out of bed at 3 o'clock in the morning, but it was worth it because when you look at these ROC curves, which give you the ratio of false positives to true positives, you will see that 1 would be a perfect score. And we were sitting at 0.9979 for the 35 and unders, and at 0.9847 for the age 36 and older. I divided the group up because estrogen production tends to taper off 36 and above. He asked me how I felt, and I said I hated him at the time because now I was never going to be able to sleep for the next 30 years because we really had the key to diagnosing this disease non-invasively. So you go in and you evaluate every single frequency band, every single variable. And this is what we came up with, is that if we looked at the 30 to 40 cycle per minute and 40 to 50 cycle per minute, in addition to their standardized endo 4D pain scores, we had sensitivities of 95, specificities of 96%, and remarkably, a C statistic of greater than 99%. Now, for those who don't know what a C statistic is, that means what is the chance you have the disease if your test is positive? So extremely strong findings, similar across the entire age groups. So what do you do? Well, now that you've got a test and you're really worried that it's going to be a really good test, is you go to a place that will test it for you just initially to get your initial clinical data. And so we were fortunate enough to go to the Najat Institute out in California. And we took 9 patients and we tested them. And we taught the technicians, they were blinded to the patients, the physicians who were doing the surgery were blinded to the results. And as you can see here, the normal patient scores were in the 0.06, 0.05 range. But those patients who were positive and normal, I mean, above normal is 0.5 or higher, were all in the 0.6 to 0.99 range. Now, initially, we thought this might be tied to stage. That turned out to be wrong from some of our initial assumptions. But what those numbers actually do reflect is the metabolic activity or severity of that disease in terms of its activity within the human body. Well, once we had that, we thought, well, let's go ahead and prove that concept. If we're actually measuring the activity, we should be able to look at the post-operative or post-medication monitoring and see changes so that we can predict whether therapy is successful. And so locally here at the Mercy Medical Center up here near Baltimore, we started to look at patients, and I'm going to show you a couple of them. This is 2 months post-surgery. This is a stage 4 disease patient. She scored 0.9232, as you can see here, and 2 months after surgery, where they really did remove everything that was visible that could be seen. Now her levels are in the normal range of 0.1473. Another one similarly, and we have papers coming out on this with very large cohorts. There's another patient here. This is prior to their surgery, 0.9979, following surgery, 0.0357. The beauty here is that when these patients come out of remission and the disease comes back, their results will go back up. So as a surgeon, if you're faced 6 months later with recurring pain, if the EndoShort test remains in the normal range, you're dealing with another problem, maybe best dealt with the pelvic floor physiotherapist. But if it goes back up, then you're going to have to deal with the recurrent endometriosis. Similarly, when we look at a very, very difficult group for everyone, which is the adolescents, and by the way, we are approved for all age groups, literally menarche to grave. These are teenagers. These are 16 and 17-year-old teenagers who were placed on Ryquo. And you can see here, there's a 15% decrease in the scores, which corresponded to a 15% decrease in the patient's symptomatology, only matched by the second 16-year-old who actually went into the normal range with a complete resolution of all symptoms. Some of this data was already presented last year in the meetings in Istanbul, and we have a larger series that's pending publication. So we can look at a lot of different, do you have the disease, and are you getting better? And this data has resulted in pharmaceutical companies coming to us to ask to use our test to judge if their drugs work or not. We've had confirmatory tests done. Here's one that was done at CHU Bruggeman in Brussels, where we were being compared to transvaginal ultrasound In 81 patients, the EndoSure test was positive in 81, and the transvaginal ultrasound was positive in 79, and they used laparoscopic surgery to determine which was correct. And the transvaginal ultrasound, as you would expect, missed the 2 patients who had superficial endo. So the EndoSure test was literally 100% predictive and 98% sensitive. If we go to the University of Sao Paulo, the home of transvaginal ultrasound, this is with Mauricio Brau and his unit. In the laparoscopically confirmed group, once again, EndoSure was a very high sensitivity and specificity in determining whether the patient was positive or not. And then finally, these are all coming out for publication soon. Shiva Hospital, where they did a comparative trial of 75 patients, they took women coming in for surgery for endometriosis and women coming in for benign surgery, not for endometriosis. And we were again, once again, almost completely able to predict who had endometriosis and who didn't in both of these cohorts, giving us a specificity of 96% and a sensitivity of 92% with a diagnostic accuracy of 98%. These type of findings have had a very interesting effect around the world where the test is being used, where I get calls weekly from surgeons who are saying, you know, I was operating for 2.5 to 3 hours and I wasn't finding the disease, but the EndoSure test was positive and I heard you whispering in the back of my ear, no false positives, no false positives. And I decided to work a little harder, and now all of a sudden here in my WhatsApp, I have a picture of a 1 millimeter lesion hiding behind the liver that they were able to find and convert that patient from a false negative to a true positive. And so I think that's the effect of all diagnostic testing, not only ours. So at the end of the day, what we have is the first tier 1 diagnostic test, which will be we hope to be a screening standard. It's highly accurate. It provides rapid results. It's easy to perform with unrestricted applicability. Not only that, but it will guide subsequent resource utilization, reflecting the spectrum of disease and the activity or the burden, as well as the post-treatment monitoring and effectiveness. It no doubt will help with new drug development and testing. And one thing that came out that was very surprising to us, in the OB literature, there are so many papers and meta-analyses showing that endometriosis, especially silent endometriosis, mostly the superficial type, is associated with extremely high complications in the maternal complications as well as postpartum complications. 51% increased incidence of miscarriage, 79% of preeclampsia, which kills mothers and babies. And so if you use tests, any diagnostic testing, but ours in particular, especially in the adolescent population, we will then also provide you with an accurate pre-pregnancy screening to give a risk factor so that when they finally do become pregnant, the obstetricians will be on the lookout for things going wrong. The test is low cost and portable, resource non-intensive. A technician does the study, so low technical skills required. There are no biological or laboratory specimens needed, nothing to save, to send, to analyze, and then to be destroyed. And what we're doing effectively is we're decentralizing diagnostic services. And that's the key to eliminating the geographic limitations, such as you find in the 40% of patients that live in the medical deserts here, even in the United States. We also equalize the financial discrimination because of the cost and reimbursement for the test. So we have accurate screening from menarche to menopause. We are approved where we are approved as a diagnostic, not an aid, but an actual diagnostic test. All of our data is surgically verified in all of our studies, everything, including the post-surgical and medical treatment monitoring of recurrence. We're going to, we think, transform diagnostic algorithms because of the known incidence of endometriosis and infertility, pelvic pain, and especially in the adolescent population. If we can get to the adolescent population and treat them and suppress them, we can likely wipe out 60% of adult end-stage disease in less than a decade with incredible cost savings. And then finally, pre-pregnancy screening to predict postnatal complications will be extremely critical going forward with, just in the United States alone, 1.1 million women getting pregnant for the first time in their lives available to screen. Where are we? This is my final slide. Where are we? Well, we've just been approved by NICE in the UK, so NHS is reimbursing our test and endorsing it as a first-line test for endometriosis. There'll be a 3-year study period to check how that works out within the system. We have just received CE-MDR, meaning we're now going to be able to be in Europe. In the US, because this is part of a predicate device that already exists, and we've already evaluated this with the AMA, there's already a level 1 CPT code with coverage by majority of insurers, including the largest insurer that pays the least, which would be United Healthcare. It will be available literally to anyone that has insurance, including medical assistants in all 50 states. FDA de novo application is going to be placed sometime the end of August. We expect that approval as a diagnostic aid in Q1 or Q2 of 2027, which will make us the only FDA-approved test for endometriosis. And we already have additional regulatory approvals in Canada, Israel, the Gulf states, Brazil, and Australia actually coming in Q4. So finally, to sum up, not only does this GI biomarker predict endometriosis and help to guide therapy, but it is the first tier 1 diagnostic. And is it too good to be true technology? Yes, it is. But when you get it in your hands, you'll see it's just exactly that accurate. And I thank you so much for this opportunity.
Thank you so much. That was great. As we are wrapping up, I would just want to, there's a lot of questions in the chat, and I do want to get to some of them. Let's start with that. Dr. Conrad, what do you think? One of the questions they have is that who should be ordering this test? Should it be MIG surgeon? Should it be family medicine? Should it be regular OBGYN or REI? Who should be ordering these biomarkers?
Who should be doing what? Diagnosing?
The test, the test, the biomarkers. Who should be ordering those tests?
Okay, so just by women, most women go to the OBGYN. So, I would say just mostly OBGYNs, fertility docs second in line, medical people, maybe it depends on whether the woman goes to see a family practitioner or nurse practitioner. But to get the OBGYN interested, it takes a while. And they're so busy that it needs to be something quick and easy to interpret with the knowledge of what a negative and positive means. So to answer your question, I'd say just about every fertility institute's going to do it. And then the OBGYNs.
Okay, great. The next question is for Dr. Noor, that how can you be sure that no other related diseases might be causing positive results with your test?
Well, thank you. And that's actually the reason why it took so long to bring this test out and do the pivotal trial is we really spent 10 years studying over 4,500 women with every disease other than ovarian cancer, which is actually something we'd like to study. So we know that there's no other diseases that do this. Actually, the only exception is when we studied the 4,500 women in the frequency of 12 to 18 cycles per minute, gallbladder disease is easily diagnosable at that point. So we restrict our frequency search for 20 to 60, so we eliminate that confounding illness. So far in all of our trials, we have not seen any other illness that caused this. Oh, and I think there was a question asked early on about whether we're able to detect adenomyosis. And in fact, that activity index does change. Patients with adenomyosis tend to have activity indices between 0.5 and 0.7, and endometriosis typically from 0.7 and higher. And but more study is going to be needed. It's so hard to find pure adenomyosis. Usually about 90% odd percent of it occurs concomitantly with endo. So we're looking for anyone with adenomyosis that we can study at this point that has been proven to have pure adeno.
Okay. Thank you. This question is for Dr. Levin. That do you have data showing that use of endom test reduces effectively diagnostic delay?
It's a little too soon to have that data, given that we introduced the test last summer, but we have studies underway. I guess what I can say is, given it's a less than 14-day turnaround time to a result with about 100% positive predictive value, I think the handwriting is on the wall in terms of how quickly you can get a confirmation of a positive result, a diagnostic result out of it.
And I think to follow up this question, this is probably for all of the speakers, that why do we think that ACOG in the recent guidelines is still against biomarker testing?
Well, ACOG takes a while to come around to many different things. They're very cautious for many reasons when they make a statement to support something that opens a whole bag of worms. You know what I mean? It just gets out of hand. So they're very cautious, and they're waiting to see more studies to validate what the other speakers are thinking about and how can they apply this. So I would say they're a very conservative organization in what they do, and that's probably the reason why.
Yeah, that is true. That like it takes a while. The follow-up question I have, like for you all, is that do you worry about this test being misused?
The test gets released to the marketplace, and the marketplace does what it wants with the test. There will be people who use these tests instead of taking someone to surgery initially, and as a reason to put them on medical therapy. That's perhaps not such a bad thing. And I think that's one of the most important things that we can say is that a negative test, no matter whose test it is, a negative test is a reason to go find out why there's still symptoms and why there's a problem, and not to just reject endometriosis or any other diagnosis. So negative test, look harder, don't give up. Positive test, decide on what treatment or whether you're going to go to surgery.
I'm not sure this is part of this podcast, but it behooves me now why it takes so long. Why are the OBs and practitioners, nurse practitioners, family practitioners, OBs, why are they ignoring patients' symptoms? It's at least 3 times a day I'll hear patients, I've been in such pain and complaining for years. And so I think if these tests become easy and readily available, at least maybe the patient will be referred to somebody that will say, yeah, you got it, let's operate on it. And a lot of patients don't want medical therapy. So believe it or not, they don't, because the medical therapies to treat endometriosis do have side effects, do have risks. Patients, they're asking AI now, they're all over the internet. They come in, I'm not taking that drug because of this and that. And sometimes, I got to tell you, a simple laparoscopy will change a patient's life. And it's a quick procedure. Steve will tell you this. Steve McCarris says a simple laparoscopy, excise some focal endo, right? Asha, you know that. And they're good as new. And that could last forever, you never know. But especially young girls. I've had endometriosis in girls as young as 15. And the biggest stage 4 I've ever seen was age 16 endometriomas. And we don't want to let it get there. We don't want to get to stage 4. We want to get endo when it's stage 1 and 2. I think that's really, really important.
And I think there's something that we're hoping for with regard to that is if we can use these tests to show when the disease has come back and when it remains in remission. That may encourage more people to decide to have surgery because they can track it. Right now, after surgery, you have nothing to track recurrence or maintenance of remission with this disease, perhaps other than from our data that we have with EndoSure.
Well, this was all really, really, great discussions, great questions being answered by you all. And I really, with the interest of time, as we have just about a minute left, I would like to thank you all for your outstanding presentations and sharing your expertise and insights around this diagnostic testing. I clearly learned a lot from you all today. I also want to thank all the participants for joining us. I could see the chat going off with all these thoughtful questions and discussions. And on behalf of American Institute of Minimally Invasive Surgery Education, thank you for being part of this important educational series. I also would like to invite you and join us for our 3rd webinar in this 3-part series on August 26th at 8 p.m. Eastern Time. And the topic will be surgery alone is not the answer for long-term endometriosis treatment, and why not? This session will explore endometriosis, complete strategy for treatment. So please mark your calendars and plan to join us for what promises to be another informative and engaging discussion. And I really thank you for your participation and hopefully see you soon in August. Thank you, everyone.
Thank you. It was a pleasure.
Thank you.
Thank you.